So fentanyl, also known as sublimase. This is a pure opioid agonist. So what makes it different from morphine? Morphine, what makes this different is it's lipophilic, meaning it's soluble in fat. This makes it that it's a fast onset and short duration. Think of like similar to the concept of phenobarbital, why phenobarbital is considered a slower acting barbiturate. This one, fentanyl, is considered lipophilic, has more lipids, and so it's fast onset and short duration, which gives it its unique properties and why it would be used in the hospital setting. All right, so for example, like IV would be used with that rapid effect, when a rapid effect is desired. So this is used for severe escalating pain and procedural pain, all right? But be mindful that every single route has different indications, and that is like the major thing with fentanyl to know. So just think when a short duration of action is desirable, this is when you would use it in procedural pain and you think of your severe escalating pain. This is recommended in end organ failure because there's no clinically relevant metabolites and hemodynamically unstable patients. So you're thinking of your critically ill patients for adverse effects. So now we're gonna discuss the routes. So there's 4 different routes from our PowerPoint that I noticed. So there's transdermal, parental, nasal spray, and your transmucosal. Again, transdermal, parental, nasal spray, and your transmucosal. Okay, so your transdermal is going to be that persistent severe pain, but remember this, only opioid tolerant patients. All right, so transdermal, persistent pain for only opioid tolerant patients. So you're thinking of your patch. Parental is for your IM and IV. So parental would be your induction or maintenance of surgical anesthesia. All right, so that's when you would be using it. So the only one that you would be using for your non-opioid tolerant patients would be your parental route. So parental, IM, IV, and induction or maintenance of surgical anesthesia. All right, so your nasal spray would be used for your breakthrough cancer pain. This would be patients already opioid tolerant, or at least taking opioids around the clock, and they have to be tolerant to some degree. So the patient has to be, for this breakthrough cancer pain of a nasal spray, would be at least 18 years old. So like that nasal spray, you have to at least be 18 years old of age. Your transmucosal is similar to your nasal spray, so this is probably also used, your transmucosal, for your breakthrough cancer pain. It has to be opioid tolerant and at least 18 years of age. So there's like 5 different types of transmucosal. You're going to think of your lisidenzines, I can't say that right, on a stick, your buccal film or your buccal tablet, your sublingual spray or your sublingual tablet. So there's a lot of routes for that. All right, so now we're going to talk about your pregnancy. So this is a pregnancy class C. It does cross the placenta, it does cross your breast milk, and as Yvette says, your blood vessels go everywhere, so it does, in this case, it does cross. It may be used for pain and labor, but just remember, if it's used for pain and labor, it is an injection, so it wouldn't be your patch, your nasal spray, or your transmucosal. Why? Because those are only for opioid tolerant patients. For the parental route is the only route that could be used for other indications of other than opioid tolerant patients. Okay. So your injection may be used for your pain and labor. So just remember if they do use fentanyl, and mostly usually they use your epidural morphine sulfate, but this may be because maybe they're already opioid tolerant mothers and they need something stronger. So they're temporarily. Look for the heart rate of the fetus, monitor that, because it can temporarily affect the heart rate of the fetus, and also your transient muscle rigidity can happen to the infant, but it's transient. Also, this is very interesting, I found this fascinating, is it actually has not been indicated to be any different from a mother who was not treated with fentanyl for the respirations or the neurological effects. So it did not affect neurological or respirations to the fetus any different from another mother. So if the mother is breastfeeding and they're on fentanyl, watch for if it's one single dose, it's not like the worst thing in the world. So way to put it. If they're basically if they're on more, it's not exactly told by the manufacturer, but it's not really advised. But if they're just on one single dose, watch for the sleep apnea in the infant and as well as the sedation. All right, so now we're going to talk about adverse effects, what it can go wrong with this medication, what we should be looking for in these patients that is not good, basically, is a way to put it. So your respiratory depression is like the main blinking lights, like look for that, you know? Make sure that you monitor those respiratory rates. Sedation, constipation, constipations with all narcotics, urinary retention, nausea, and what's different about fentanyl is you'll be also looking for muscle rigidity. All right. So with transmucosal, it's a little bit different. Actually, so in transmucosal, the most common side effects, including your respiratory depression, would be dizziness, anxiety, and confusion, because think of transmucosal as closer to your head. Nausea, vomiting, constipation, dyspnea, weakness, and headache. Respiratory depression and shock is the main concerns, though. Still. All right. So what is it contraindicated for? The patch is definitely not for, it's not, anything that's not opioid tolerant would not be indicated for the patch. Alcoholism, delirium tremens, convulsions. Think of your convulsions. What are those patients on? What kind of medications are they on? They're already on CNS suppressants oftentimes with your seizure patients. If your intracranial pressure is elevated, labor and delivery, a pregnant patient is not given a patch. Remember, only the injection form, so route does matter. The MOIs within 14 days. Why? Because that's a depressant. A nursing mother, so those are basically for the patch. That's like a no-no. So basically, not anybody that's opioid tolerant. For the injection route, you're gonna want to look for things that like a hemorrhage. Don't have it with a patient who has hemorrhage or shock or anticoagulant therapy. Think about like if you're gonna put an injection in someone, they have a risk for bleeding. You shouldn't be injecting them then. And septicemia is another one. So also they say in the PowerPoint, anything that's contraindicated for an epidural is also contraindicated for this injection of fentanyl. All right, sublingual says severe respiratory depression and lung diseases because you think you're obstruction, but really everything is at risk for respiratory depression and your lung disease. You may be wanting to look for other side effects that are not as detrimental, would be like your dry mouth or your tingling of your mouth because it's in that sublingual area. The other general ones, so the general for the overviewing stuff would be your significant respiratory depression, your lung disease, your GI obstruction, paralytic ileus, and then there's this thing that was in there that said cetylpridinium. Pretty sure that's just a medication that's not okay to take at the same time. So these are all just general overarching no-nos. If you have this, don't take this medication. All right. So what is the nurse's job when they're on fentanyl? What are they going to monitor or teach? So they're going to monitor for the respiratory rates and the cardiovascular status, their blood pressure, their heart rate, signs of misuse, abuse, and addiction, because this is a narcotic and you got to watch out for those patients being addicted and stuff like that. So also signs and symptoms of hypogonadism and hypoadrenalism, which is just look for that depression. Like if you have your adrenal glands are hypo, it means they're not producing enough epinephrine, and think of all those hormones that are released. So you're going to be really tired and lethargic probably. Transdermal, the main thing is to watch those patients for the first 24 hours of the first dose. Transdermal is that patch, that one for opioid tolerant patients. But let's say if you already know that a non-opioid tolerant patient, it's at severe risk for respiratory depression and coma and death, then you know even with the already opioid tolerant patients that this is a severe risk already. So you want to make sure that this patch is how the patient's going to react to it. You want to assess for pain relief and see if it's working. Is this effective for the patient? Monitoring and managing for their nausea and vomiting symptoms, excessive sedation, and constipation, which is adverse effects associated with the fentanyl. And monitoring a baseline liver function is important. Also, you probably should obtain one prior to the administration of the patient taking fentanyl. So patient education, we'll talk about soon, but also if they're discontinue slowly, because it is a narcotic, and safety measures should be in place because they're at risk for falls. And also, if they're an outpatient and they're taking fentanyl, let's say, then you should tell them that they need their house to be safe, like rugs and stuff like that. And that is everything. So after that, we just can talk about patient education. So the patch this is really interesting because apparently heat accelerates fentanyl. It accelerates the release of fentanyl being released, and it's already a fast narcotic. That's what makes it so different from morphine, is that it's rapid. It's lipophilic, remember? So if it's exposed to direct heat, it will increase that release, which is really dangerous, and you can reach those that dangerous level of respiratory depressions and the side effects faster. Fever, your internal heat also can make an effect on this and increase this risk. Fever, sunbathing, just being in the sun, strenuous exercise, anything that internally increases that heat inside of you can increase that release of fentanyl in your body. So other things to know is, how do you dispose this medication? So you fold it in half with the medication side touching, and you just flush it down the toilet. And that's it. So also to know, and if the patient's taking intranasal, which is for that breakthrough cancer pain, they may be taking it at home, you don't know. Teach that patient at least between doses to have 2 hours. So between like 2 doses, you have to have 2 hours. And if it's more than 5 days, you're taking them more than 5 days elapsed between the medications you've been taking, you're gonna have to discard that bottle and replace it. So let the patient know, or the nurse needs to know if it's inpatient. Another thing is, avoid applying the patch in the same place twice. So remember, when you're in lab, you use it one, you clean it, wipe it off with a napkin, just paper, not alcohol or anything, and then put it on a new side. All right, the last thing that you need to remember is avoid concurrent use with grapefruit. So that's the last thing, and that is everything. So avoid grapefruit use with fentanyl, and that's everything that has to do with naloxone. No, I meant fentanyl. Naloxone is your opioid antagonist. So, it's also important. If they have respiratory depressions, administer naloxone unless they were, this is for patients who are opioid tolerant, which is very interesting. That's a great point. So if they're opioid tolerant and they needed a naloxone, you have to make sure to be really careful when they're, if they are given naloxone, because you have to titrate up and start slow, because they can have all the reverse reactions of opioid withdrawal. All right, so avoid concurrent use with grapefruit, and that's everything for fentanyl.